So, chorea is an abnormal involuntary movement characterized by brief, abrupt, irregular, and predictable non-stereotype movement. It affects various parts of the body and interfere with daily activity like speech, swallowing, posture, and gait. Chorea may worsen with anxiety and voluntary movement, and it subsides during sleep. The causes of chorea are so many, so it's either acquired or hereditary or miscellaneous causes. The acquired causes of chorea includes Sydenham chorea, chorea gravidarum, or cerebrovascular accident, cerebral palsy. Also, there are different drugs that cause chorea like levodopa, antipsychotic, phenytoin, lithium, oral contraceptive. The hereditary causes is either Huntington disease, Wilson disease, benign hereditary chorea, or familial chorea with acanthocytosis. The miscellaneous causes of chorea include metabolic causes and other autoimmune disease that may cause chorea, like thyrotoxicosis, Addison disease, SLE, antiphospholipid syndrome, and so on. In this slide, we talk about the Huntington chorea, which is a neurodegenerative disorder characterized by a gradual onset of subsequent progression of chorea and dementia. So, the Huntington chorea is accompanying of chorea and dementia. It is also autosomal dominant due to mutation of Huntington gene on the short chromosome number on the short arm of chromosome number 4. The symptoms usually don't appear until the adulthood, typically between the age of 30 to 50 years. Approximately 5 per 100,000 of population the prevalence of chorea. As we said, the clinical features of Huntington chorea is accompanying of dementia and chorea, and the earliest mental changes in dementia consist of irritability, moodiness, and antisocial behavior, impairment of attention, and executive dysfunction. While in the chorea, initially, as we said in the definition of the chorea, cause restlessness, fidgetiness, but abnormal coriform movement are eventually seen. There is a typical form of Huntington chorea, which we call it Westphal variant. The presentation of Westphal variant of chorea like Parkinsonism. It is dominated by progressive rigidity and akinesia, with little or no chorea during adulthood and occasionally during the childhood. The definite diagnosis of Huntington chorea is by genetic testing. So the genetic testing now provide an accurate and definite diagnosis of Huntington chorea. Also, some blood tests we should do to exclude other causes of chorea like Wilson disease, a blood test for acanthocytosis, antistreptolysin ASO titer for Sydenham chorea, and thyroid function test, and as I said, to exclude other causes of chorea. There is no cure for Huntington chorea, but we treat chorea at a symptomatic treatment for chorea, which is dopamine receptor blocker like olanzapine, risperidone, and quetiapine, and also we use dopamine depleting agent, reserpine, tetrabenazine, or benzodiazepine like clonazepam. All these are symptomatic treatment for chorea in any disease that causes chorea. Also, we use fluoxetine or nortriptyline to treat the depression and irritability that occur in the patient with Huntington chorea. Other type of chorea is the Sydenham chorea, which is occur typically in children and adolescents as a complication of a previous group A hemolytic streptococcal infection. It is the most common chorea in children, and the age typically at a 5 to 15 years old. It appears 2 to 3 months after an episode of rheumatic fever or polyarthritis. It characterized by acute onset of coriform movement and behavioral disturbance. Chorea generally subsiding within the following 4 to 6 months without treatment. If we need treatment in Sydenham chorea, so we use the dopamine blocking agent or valproic acid and carbamazepine. So, now what is dystonia? The dystonia is a syndrome of involuntary, sustained, or spasmodic contraction involving co-contraction of agonist and antagonist muscles. So, the movement is usually slow, sustained, and often occur in a repetitive manner. Due to this movement, abnormal posture and twisting can be painful, and as you see in the video, the patient have cervical dystonia, which is the most common form of focal dystonia. Classification of dystonia is based on either on the age at onset or anatomic distribution or etiology. So the classification of dystonia according to the age as the follow: either infantile dystonia, which is occurred before 2 years, or childhood dystonia from 3 to 12 years, or juvenile dystonia from 13 to 20 years, and adult dystonia after the age of 20. The classification according to the anatomic distribution, it is either focal dystonia or segmental dystonia, multifocal dystonia, generalized, or hemidystonia. The etiologic classification of dystonia is either primary, which is idiopathic, like idiopathic torsion dystonia, the most common form, or secondary dystonia, and this may be as a result of different neurological disease or inherited metabolic defect, like Huntington disease, Haloverden-Spaz disease, Wilson disease, lipid storage, Parkinsonism, Leigh disease, and other causes that cause dystonia. In this slide, we discuss the primary form of dystonia, which is called idiopathic torsion dystonia or Oppenheim dystonia, is the best example for primary dystonia, and it is an autosomal dominant inheritance that primarily affect Ashkenazi Jewish families, and the age at onset is younger than 25. Typically, mean age is 14 years. Dystonia typically begin in the foot or arm and progress to involve other limbs. So the patient come with difficulty in walking due to dystonia of the foot. Other type of dystonia is dopamine responsive dystonia or Sigawa variant. It is also autosomal dominant form of childhood onset dystonia and typically present in early childhood from the age of 1 to 12 years, is characterized by foot dystonia that interfere with walking. Patients often experience diurnal fluctuation with worsening of the gait as the day progresses and improvement with the sleep. Dopamine responsive dystonia, typified by an excellent response to small dose of levodopa. So, in children and adolescents with dystonia, we must give patient a trial of dopamine to exclude dopamine responsive dystonia. In the previous slide, we discussed different types of generalized dystonia. In this slide, we talk about the different types of focal dystonia, and the most common type of focal dystonia is, as we said, cervical, which is dystonic contraction of the neck muscle, causing the head deviate to lateral side, and we call it torticollis, or deviate the head forward, we call it anterocollis, or backward retrocollis. Other type of focal dystonia is the oromandibular dystonia, which is due to contraction of muscle of the lower face, lips, tongue, and jaw, opening and closing. And there is a syndrome, we call it MEX syndrome, is a combination of oromandibular dystonia and blepharospasm, and this MEX syndrome predominantly affects women over the age of 60 years. Other type of focal dystonia, the blepharospasm, which is a dystonic contraction of eyelid with increased blinking that interfere with reading, watching TV, or driving. The last type of focal dystonia, the task-specific dystonia, which is a dystonic contraction of muscle of the hand during writing, and we call it writer cramps, or during play a musical piano, and we call it musician cramps. Treatment of dystonia. The cornerstone of treatment of dystonia is the treatment of primary underlying cause. Other type of treatment is we use anticholinergic like triacylphenidil or baclofen or clonazepam. So you must know the treatment of dystonia as A, B, C. A, anticholinergic, B, baclofen, C, clonazepam. Other drugs used for the treatment of dystonia is tetrabenazine. Also, botulinum toxin is a preferred treatment for patients with focal dystonia, especially cervical dystonia. If the medical treatment is failed to control the dystonia, so we refer the patient to surgery, and the best surgery for dystonia is the deep brain stimulation of pallidum, globus pallidus, can provide dramatic benefit for patients with primary dystonia. Oculogaric crisis. We see this crisis. We see this crisis in the emergency, and from its name, the dystonic reaction occur due to some drugs like metoclopramide or neuroleptic like olanzapine. So it is a dystonic reaction to certain drug. We call it oculogaric crisis. It is self-limiting crisis. Do not treatment. If we need a treatment, we treat the oculogaric crisis by antimuscarinic, procyclidine, or diphenhydramine, or diazepam. Now, what is the definition of tic? Tic is a sudden, recurrent, quick, and coordinated abnormal movement that can usually be imitated without difficulty. And the same movement occur again and again and can suppress voluntary for a short period. Tic tend to worsen with stress and diminish during voluntary activity or mental concentration and disappear during sleep. And the video in this slide show you a, a, a type of motor tic that occur in disease which call it tic dilatorate syndrome, and we discuss the tic dilatorate syndrome in the coming slides. How we classify the tic? It's classified either transient simple tic, which is very common in children and usually terminates spontaneously within 1 year, and generally no required for treatment for this type of tic. The second type of tic is a chronic simple tic. This can develop at any age, often being in childhood, and also treatment is unnecessary in this type of tick. The third type is persistent, simple, or multiple tick, occur in children and adolescents, generally begin before the age of 15 years, and the treatment, if the tick is disturbed bothering the patient, we treat it by certain drug which we discuss it in the following slide. The last type of tick is the chronic multiple motor and vocal tick, which is atypical of Gill's dilatorate syndrome. In this slide, as you see in the video, the patient have typical disease which we call it Gill's dilatorate syndrome. It is typically characterized by chronic lifelong multiple motor and vocal tic and verbal tic. It is of unknown cause and does not relate to social class or ethnic group or perinatal abnormality and birth trauma. Symptoms begin before the 21 years of old, but typically it begins before the age of 11, and the course is one of remission and relapse. Most cases are sporadic. Occasionally, there is a positive family history and inheritance attributed to an autosomal dominant gene. The prevalence of Gill's dilatorate syndrome is about 0.05% and is common more in male. The diagnosis of Gill's dilatorate syndrome depends on the presentation of motor tic and vocal tic. So it consists of 80% of patients present with motor tic and 20% of patients have vocal tic. There may be a single or multiple tics at earlier presentation. The motor tic most commonly involve the face as sniffing, blinking, or forced eye closure. The vocal tic commonly consists of grunts, barks, hisses, throat clearing, or coughing. The vocal tic sometimes take the form of verbal utterance, include corpolalia. The corpolalia is vulgar or absence speech, which occurs in a half of all patients with Gill's dilatorate syndrome. The other is echolalia, which is parroting the speech of the other, and echopraxia, which imitation others' movement, or palilalia, which is referred to repetition of word or phrases. Also, patients with Gill's dilatorate syndrome may have behavioral disorder like obsessive compulsive disorder or attention deficit disorder, learning difficulties, and impulse control disorder. The neurologic examination in patients with Gill's dilatorate usually normal. The treatment of tic or Gill's dilatorate syndrome is symptomatic treatment, education of patient, family member, and teacher, cognitive behavioral therapy. Drugs that used to treat the tic is clonidine, guanfacine, and atypical antipsychotics like risperidone or aripiprazole are sometimes beneficial. In this slide, we see the hemifacial spasm, which is type of hyperkinetic movement disorder characterized by repetitive involuntary contraction of some or all muscle supplied by one facial nerve. The symptom more in orbicularis oculi and then spread to the cheek and levator anguli, oris muscle. It is provoked by blinking or voluntary activity. A slight facial weakness may be found on examination, and patients with hemifacial spasm commonly we send them for neuroimaging and MRI brain and MRI because it must be due It may be due to the presence of an anomalous blood vessel compressing the intracranial facial nerve. So we do the MRI brain MRI for the patient present with hemifacial spasm. The treatment, the medical treatment is by anti-epileptic like carbamazepine or phenytoin. The hemifacial spasm is refractory to treatment in most cases, so we shift the patient to took an injection with botulinum toxin into affected muscle. Some patients need microvascular decompression surgical procedure are often curative for patients with hemifacial spasm. This patient, as you see in the video, has hemipallismus. The hemipallismus is a lesion in the subthalamic nucleus, and mostly it may be due to a vascular origin like infarction or hemorrhage, and it is characterized by wild, flinging, large amplitude movement on one side of the body, and the proximal muscle of the limb tend to be predominantly affected. Lastly, athetosis, which is a slow distal writhing involuntary movement with a propensity to affect the arm and hand. As you see in the video, this is typical form of athetosis, and the cause of athetosis is like chorea and most cases due to cerebral palsy. Thank you very much for listening.